thank you for you prepare the cases, right? And thank you. Hi, Dr. Mark. Mark is going to be my fellow. I'm very excited. 我们已经有 project for you. We have so much going on. Okay. 所以这样子好。然后 it's interesting. 现在我们第一个 case, right, is oligometastases. 然后刚好 Jillian's talking about it, right? 其实我可以 give you my thoughts about oligometastases. I think it's really good. 可是你如果看所有的 data, 哈 it's really kind of scary. 你知道 oligometastases 它都是 the trials are positive when they are small. Whoa, this is echo. 是不是？哇，好大声！会不会太那个？这边关了，这边关了，这关了哈。呀，这个是关的。对呀。OK， 好。呀，然后你看那个 oligometastases, they're very， 你看所有的 positive trial 都是很小的 ，very small study. It's actually dangerous. 所以我跟 Jillian 讲 ，you know, Jillian, we had a really good Lancet article, 可是 very small. So I told her like, 你要 design, be careful, 因为你到了 phase 3, right? That's what happened with the LU009, whatever the energy oncology trial by Puneet. Puneet is negative. So 我觉得 oligometastasis is something we have to think about. 其实都是 patient selection. You have to be really careful. 然后你弄那个 large randomized studies 的时候。很多东西 factor 会 wash out, so you have to be very careful. So it's almost like 我们 jokingly say, you know, don't go to phase 3, just go to phase 2 randomized and stop. 因为我觉得我们的放疗这个科呢有一点危机，我不知道在台湾是怎么样，在美国其实有很多 immunotherapy. 现在那个medical oncologist 跟那个外科医生 team up, 对不对？他们就给一些 immunotherapy 然后开刀，然后把 radiation squeeze out. So something we have to think about. Okay, 可是 metastatic world is one way. 我觉得 in the future, it is where we grow our patient volume. 你像你看 lung cancer early stage wipe out. 你看 breast cancer is getting wiped out, right? 这些 bread and butter. Head and neck 他们已经开始来了嘛 They're coming, okay? I can tell you that. So 我们要怎么 fight against? But one area is we can grow indication for metastases. Okay, so let me see if I can advance this. Oh, I can't advance this. This one, this one, this one, this one. Okay, maybe here. Oh, 我用这个就好了。这里不行哈。Okay, so this is, I thought this was a very interesting case. 51-year-old female. So this tells you age is important, right? Good performance status, KPS on 90, not much medical morbidity. In September 2024, and has some bilateral oral fullness, and then an exam found nasopharyngeal cancer. This is really, really interesting because the way I think of Asian nasopharyngeal cancer, generally they present with neck metastases. Okay, basically, hi. And basically, they present with 很大的那个 lymph node metastases, right? So here, you know, EBV viral load. Let me ask, how many you guys do viral load routinely? Because that's something we haven't done. We do the plasma EBV DNA, right? That's what we generally do. But here are EBV positive. And then you have, here's the nasopharyngeal cancer right here. You got your retropharyngeal node. There's something weird here, but who knows what that is. But basically, there is some mets in T9 and 2 hepatic lesions. So usually, I don't know about in Taiwan, but I suppose this case probably did the same thing. But generally, we will biopsy, right? Making sure it's really, truly metastatic disease. And then what do you do afterwards, right? So here you have this case, right? And level 1. Can I ask a question? How many of you guys will cover level 1B for nasopharyngeal cancer? Never, right? Even with no positive, you still don't, right? We used to, but in 2013, I went back to China. You know, China is the hub of nasopharynx. They never cover 1B, so I stopped 1B. So it doesn't matter if you're no positive or negative, we never cover 1B. When you don't do 1B, guess what? Your oral cavity dose goes down. And then you really have a good sparing. Okay, so for this patient, this looks like a very, very low volume disease. I mean, I can hardly see any metastatic lesion here. There's something right here. I don't know, and then there's a here, 3 different sites, but we would probably biopsy this, but it's fine. Bone is the most common metastatic disease site for nasopharyngeal cancer, right? It's bone, then lung, then liver. So the primary tumor is not terribly large, right? It's just almost like a T1 lesion, right? With retropharyngeal nodes, but M1 disease. Let me see how they staged it. Got T3. Oh, maybe there's clival involvement right here. The clivus right here. I don't know if you guys see my arrow. Oh, 你们看不见 my arrow. Oh, yeah, pointer, 对不起，好，我看一下 pointer. Yeah, right here. But that's why I think we need an MRI. And then, of course, and if you think about it, right, this is good response. You give 3 cycles of gemcitabine and cisplatin, I think, right? And then CCRT and 33. I have to tell you guys, I don't use this regimen anymore. I stopped. After the head neck 001, I keep everybody at 2-grade perfection. Like, I don't do any escalation because I think, and I'm going to tell you guys a top secret. I'm really excited about this because nasopharynx is my passion. I have a protocol that's going to open where I'm going to de-escalate to 40-grade only, gross disease. So that will be something next. Because I'm going to talk about in the next session, if you guys go, is about my 30-grade trial. I'm going to do it for 40-grade for nasopharynx. Because if you really think about it, nasopharyngeal, EBV, Burkitt's lymphoma, NK T-cell lymphoma, they're all around 36 to 44 grade. So why is nasopharyngeal cancer going to 70? I was stuck for a while because I had a trial, Energy Oncology Head Neck 001. But after that trial's done, we're going to start de-escalating nasopharyngeal cancer. So the reason I say that is when you do, a question you think about is if you have oligometastases, right? You can either start with chemotherapy first, assess the response, and then radiate. Or what they did here, which is also, they just did 3 cycles of platinum induction, and then they went straight to concurrent, right? They did do assessment, but they went to concurrent. The question really you need to ask is, do I need to do 212 to 70 when I have M1? That's a question you ask, right? Do I need to? Maybe, maybe not. So we can talk about the data in a second, okay? And then 33, 1.8, right? 33, this is 1.64. And this is and concurrent weekly. I don't know. How many in Taiwan do people do high dose anymore? Or everybody's weekly? Weekly, sis? Weekly or high? Anybody do high dose? So we're still high dose, right? I think high dose is the way to go. But after induction, it's very hard. Very, very, very difficult. So, you know, Professor Ma, he dominates nasopharyngeal cancer from Sun Yat-sen, right? He's the one with the New England Journal article. But he writes that they went for high dose, but it's very difficult, I could tell you that. We almost have to dose reduce, or we have to switch to weekly. So I can understand why weekly. And then here's metastases, comprehensive RT right here to the areas. This is very interesting. Wow. Like SBRT here. And okay, so anybody have a problem with this? I think this is fine. The only thing I might have done a little differently is if I see a good response, right? I drop my subclinical. In nasopharyngeal cancer, our subclinical routinely is 40 grade now, 40 in 2-grade perfection. We don't do 50 anymore. We, as a team, decide to go lower because I don't think we need that much, especially after induction chemotherapy. And then the gross disease post-chemo is when we go to 70. Okay, here. Oh, this is a volume. It's beautiful volume. I don't know who did it, but it was very nice. But I don't know if I would treat that. I just want to tell you guys that. I don't know if I would contour that. How many people would contour that after induction? Because it was PET negative, right? Let's go back. Was it PET negative?
Slice the value.
Oh, okay. Maybe. Sorry. But very nice contours, though. Oh, yeah. Oh, wow.
Wait, all right.
Oh, is this your case?
Yeah.
Oh, beautiful case. Okay. Sorry. God, I didn't say anything negative. Just kidding. Having fun with you guys.
So this is a size by size.
Yeah. Okay. Some size by. Oh, 就这样用这个
Yeah, you can go.
arrow.
Up
Okay.
and down.
好。Yeah, very nice contour. See, I really like it. I thought nasal pharynx. Yeah. I mean, I think this is beautiful. I do exactly the same. See, you see the clivus here? I just don't think you need to gamble here. I do exactly what you do. I cover it because there's no reason. Like if you have a marginal miss, it's just a nightmare, right? So here, that's nice. Question here. Yeah. And then, but I don't, this is interesting. Why do you think there'll be disease there? The reason? I mean, that would be a weird place to fail. So, because if you're going to go to 70, what happens is it's going to be pretty toxic, right? But I suppose here and then there. Was this patient treated with proton?
No, it's treated with
Proton. Oh, VMAT. Yeah, so VMAT, what's going to happen is you're going to spill right here, right? Proton is the advantage is right here. And then we have this. Very nice. Yeah, the only thing I probably would not touch that. Just kind of, I would ignore it. Because that's weird for nasopharynx to fail there. And then, yeah, because if you come back here. Because that might be, oh, I see, you're getting this little thing right here. Because that's, the other one is a vessel. And then here, oh, you did level 1B. I would have stopped right here. No 1B. Yeah, because then your 嘴巴会烂掉。那个嘴巴烂掉好难过哦。Yeah. 不过很多人在美国也是 treat 1B， 只是我因为去中国那个福州医院，他们通来都不要，我就说好，2013年开始我就再也没有，我只有一个美国人 fail in 1B， 其他都没有，所以it's nice. Here's 1B. This really beautiful contour. Look at that. It's just so nicely done. And level 5. 现在中国不是说吗？如果是 N0 就不要 treat bottom。你们有没有这样子开始？呀，我们刚开始没有，可是我被那个 peer pressure 压力太大了，所以我一开始，可是你去看那个 paper， 我们有做，怎么可能说你没有去这个 bottom 的时候，那个 dysphagia 会变得那么好？我们觉得那个 data 奇怪 ，but I think 你可以 consider, you know, do you really need to go post, you know? 所以如果我们 go post， 我们这个 dose 只有40个 gray, 40 gray into gray perfection， 我们已经 drop 了。Yeah， 因为especially when you give it with chemo, but beautiful contour though. 大家有没有什么问题 ？It's very nice contour.
Actually prepared a few
Yeah.
discussions.
Beautiful. Yeah, this is great. Okay, so question number 1. In NPC with limited but non-oligometastases, should radiotherapy target both local regional metastatic site? What oncologic benefits are anticipated? So this is actually a great paper that was published, right? It was from China, right? JAMA Oncology. 其实这个 concept 很简单，就是你有 M1, you give chemo 以后，如果它在 progress， 你就不要再 do anything。如果它 stop 的话，你就 randomize。那个 concept 其实很 very similar。然后 the importance of local region control， 其实在这个2004年的时候，我们发表一个 retrospective， 只有5 cases， 就是一模一样的。然后 we noticed that 我们如果去 sterilize the distant metastases 的话，那些病人可以活得很长。It was a very concept. I think that was the prompted 为什么他们做这个 study. But the study was very nicely done. 你看，如果你一直给 chemo 的话，哈，我看不见，这是 chemo radiotherapy, right? 然后 chemo， 如果你一直给 chemo 的话，因为为什么你这些病人 having progression of local regional disease， 所以如果你 sterilize 的话，你就可以有 better survival。可是问题就是 what is your dose？ 其实我现在越来越觉得不需要到70个 gray， 可能如果你看到剩下还有 gross disease， 你可以就在那些地方到70。我甚至有在想说，如果是 M1。需不需要 treat subclinical 那个比较 radical 一点好 but we would probably do 40 and then like that 大家有没有什么问题这个 你们知道这个 paper right？这篇文章 ？Do you know who wrote the editorial for this? Yeah, it was during COVID. 我们那个时候 COVID 的时候没有事情做，在家里干什么？干脆写 paper, right? So we did a editorial. It was very nice. It was a very nice. So that's why we know this paper very well. And then yeah, lesions noted. I don't know about yeah. This is trend. I don't know. We'll see, right? 因为你的病人蛮多 lesion, but still it's gonna do well. Yeah. So. 你有个 plan, right? Is this one contouring dose correction?
This is discussing whether
Yeah.
1B.
对，所以我们第一个 question 是 1B， 我是觉得 the likelihood 1B 是蛮低的。然后其实你看那个 1B 这个地方哈 ，next to submandibular gland 都会有一点点 activity, right? 然后呢，当然你看到的话 ，you want to， 有的时候我们不想的话，我们会 biopsy, right? 然后你们多少人会弄 1B 的 contour 1B? Very little. Hello, am I talking? 然后因为你如果没有 1B 的话，你这个地方你看就 spare。尤其如果你是做质子的话，哈 ，it's so beautiful， 就是嘴巴就不烂掉了。可质子也有自己的问题。我跟你讲，质子好 overrated。然后呢，我有一篇文章 ，I'm begging JCO to accept it， 就是说质子会有更多。Osteoradal necrosis 怎么讲中文？骨髓坏死、骨头坏死是我们看到，可是你知道 negative paper 非常难进去的。结果 it went out for review， 可是已经4个月了。我就在想，我觉得 editor 想要收，可是呢，很多 proton lover 要 say no， 所以大家就在打架。Literally， 所以我是希望，如果你们看到在 JCO 就表示 editor 1， 如果不在的话，那我就要再下去，没有关系 ，I will get the story out， 因为现在是 negative paper 非常非常难出去，大家都要 positive paper。It's kind of annoying。我等一下讲我的 lecture 是有 two very important paper， 就是 people don't want to hear the story， 他们已经 made up their mind，which I'm not about that， 我是要把 data publish。然后质子很好，可是质子对骨头要小心，如果你有质子的话，哈，质子 never 70 gray anymore， 那个骨头会有 problem。我现在质子看到骨头要降低到 under 50 gray， 不然的话，我觉得骨头会有问题。然后我甚至于做 combination attack， 我现在每一个病人是 first 3-4 weeks 都是 IMRT， 然后 boost 还是 proton， 因为我很怕那个。骨头坏，应该叫骨头坏死 ，right？ 骨头坏死，而且那个坏死很厉害 ，proton 的骨头坏死比那个调强 IMRT 还要厉害，厉害到有个病人哈，要把整个骨头全部都切掉 ，That's how bad。而且他们都是 later on 才会发生的，所以 there's something to think about. Okay, so here we got that. How about the metastatic optimal dose per fraction? Yeah, so actually that's a good question. 你觉得这个 metastatic N1 你是弄 9 grade times 3 right？ 有的现在 lung cancer 都到10 grade times 5 right？ 还有的时候是18 grade times 3， 他们现在越来越高。I'll tell you a true story。我刚刚在 Sloan-Kettering 的时候，你知道 Josh Yamada 他是 spine person right？ 一大堆做很多 paper， 然后他呢，刚开始那个时候我们很害怕啊，哎呀 ，how about 6 grade times 5？ 这是2002年、03年，我们就说 6 grade times 5， 那时候我都已经吓死了 6 grade times 5 in the head neck region。结果他就说 No 8 grade times 3， 所以我说好没关系 8 times 3， 因为他说嘛，因为他是 hypofaction 的一个 person。可是你看今天已经到了10 grade、12 grade、15 grade， 所以这是 some history。如果有 resident 在这里，告诉你们 there's some history with that。Okay, so this is great.Optimal dose per fraction. I think you can try 10 grade times 3. You can try even 6 times 5. You can do. 在美国，你知道，如果是 SBRT， 它是有个 charge code， 所以 insurance 有的时候不会 approve。我不知道中国是怎么样，所以有的时候，它如果我弄9 grade times 3 doesn't approve， 会6 grade times 6。因为你如果 above 5 fraction 就是 IMRT， 你是5 or less 是 SBRT。那你 SBRT 的话 ，insurance may not approve。那你就不付钱啊，不付钱的话你没办法。There's a lot of problem like that. It's like you guys.
The targets near the primary target. Like would you target it with?
Oh, you mean these?
Yeah, the green, like the C1 target, is next to the.
Oh, yeah. Sometimes it's so close, I include it, just in the plan. Yeah, 因为你没办法，你那个很 messy. Yeah, but that's a great question. Yes, like the C1, right? You can just include it together. You can just draw a little bit out like that. Yeah, but very good case. 在中国也台湾也看到很多这样子嘛，哈。
也没有那么多的。
Yeah.
But NPC 不少的。
对，你可以那个 check EBV DNA 嘛，你看它有没有 clear, right?
It actually dropped.
Oh, you did drop, right? Let me see. Yeah, that's right. 你看9700，可是你这是 viral load， 不是 EBV DNA.
That's just.
Oh, interesting. Okay, we don't do viral, we just do EBV DNA. 然后so 97 to 43, nice. So this person is being good. 然后oh, here's a contour. Okay, we did this one, right? And then here. Oh, we did. Yeah, contour. Yeah, see, this is beautiful like that. Okay, so does anybody have any more question? Oh, we got a minute. 是9:45, right? Oh, 我说 OK， 我有时间。Yeah, 对。
You mentioned about the higher risk of mandibular osteoradionecosis
with proton.
Proton therapy. So, is it because the possible high lean LET, or is it because we want to spare the parotid gland? So we have a very strict constraint and induce the higher dose to penetrate to the mandibular bone.
Yeah, great question. Great question. I can tell you, I don't believe the RBE is 1.1. It's definitely not. It's definitely associated with LET. But recently, just when I come here, Henry Willers from MGH did a lot of biologic work here. Probably the entrance dose of proton is the most uncertain, the RBE. That's what he thinks. So I think mainly RBE, because you can explain it. Because the planning, you can play with it. You can cool the plan, you can play with it. You spare the parotid, raise the parotid a little bit, then your bone's still okay. Yeah, I think that's what it is. But there's no question. But the thing is, the proton, I'm kind of mad at my colleagues. I know Steve Frank has a phase 3 study that's positive, right? But they didn't study dental well, but which I'm talking about a little bit. But the problem is, no one wants to write a negative paper on proton. I think it's really wrong, personally, all right? Because I think people need to know, because these patients suffer, right? So in the proton community, you're not going to find too many negative articles. You know, the one I wrote, I got so much in trouble. I wrote this paper in JAMA on otolaryngology. I'm not even a senior author. I'm a second to last. It was a dentist who wrote it. But people got so mad. They wanted me to retract. Because why? Because this puts proton in a negative light. See, that's the problem, which I don't think is the right thing to do, just so you guys know. Okay, so here, oops, sorry. We did this, right? We did this. Oh, okay. Oh, okay. Then we have a next one, right? Any other questions? Yeah.
I'm curious about the radiation dose to the metastatic region.
Yeah.
Would you use lower dose for metastatic NPC, metastatic region, or you treat it concurrently with NP area?
Very, very smart. Yeah. We do something a hybrid. Okay, so a patient comes to you for, let's say, 35 days, right? They want to go home because we have a lot of people. So in the last week or so, we add the SBRT spots. So we do SBRT like 9 grade times 3. Yeah. Although sometimes we run into insurance issue because you can't bill here and SBRT at the same time. So then when we have those issues, sometimes we will switch to sequential. It's so complex. I don't like to bring money in, but you know, I come to the conclusion, if there's no money for the hospital go bankrupt, then you don't have a job, right? So it's cyclical like that. Yeah, but that's a great question. Yeah. So the next case is by Mark Chang, my future proton fellow. You're coming in July, right? Okay, great. We'll put you to work. We are very busy. We are so busy at the Proton Center now. The care path delay is 23 days from simulation. And so we opened up our New Jersey facility. So, because there's too many patients. Okay, here. I thought this was another amazing case. Look at that tumor. 82-year-old, right? Poor performance status, but has this kind of gingival, I mean, look at that. That's just absolutely, this is probably bleeding, right? All different things, rapid growing for months. And I'm like, how did this person allow this to grow? What did he think it was? A big pimple? 青春痘吗？这么大？然后呢 so then basically, big mass, what do? Like, you're kind of stuck. Squamous cell. What would you do? Raise your hand. What would you guys do for this? Who would go to operation right away? It's a buccal cancer. You would do operation. Okay, that's fair. Some surgeon will. Chemotherapy, induction could be another one, right? Which, you know, Keynote 689 is positive. That's going to be biggest thing in AACR, right? With the 2-cycle pembrolizumab followed by surgery is better than surgery. Curves look really great. I actually participate on that study. Okay, here. Look at this. Look at this one. I mean, technically, this is resectable, right? I mean, if you think about it, right? You can kind of resect. So some surgeons will take it. There's no question. Take it to the OR. Or when it's rapidly growing, you might want to consider just giving some chemotherapy. Now, the biggest wave right now is the addition of PD-1, right? The whole induction concept actually was published by Lisa Lecitra in JCO about 15 years ago. Induction chemo followed by surgery. You change unresectable to more resectable. There was no survival difference. It was a randomized study done from Italy. And now it's just we are doing it with immunotherapy with PD-1. So you can see the mass here, a lymph node here. And then, so the person underwent, oh, look at the PET. It's a nice PET. With these, this is Mets, right? Was this Met? I wasn't sure. Oh, okay, sorry. Because I know this is it, but I don't know if you, were they Mets or just, it's just windowing? I see, yeah. So here, that's that. And then guess what this person did? Yeah, see? Next step. Operation adjuvant. I think some people would do that. That's defensible. I don't think anybody would do this, right? It's too hard. Concurrent. And the induction local therapy, palliative. I don't know if I would do palliative. I think everybody, regardless, you give them a chance. And then you look at the response. If the person's going downhill, palliative, then I do quad shot, something like that, right? Here we go. Yeah, I thought this regimen was very interesting. Is this a common Taiwan regimen? Because in the U.S., I sent this case to show my medical oncologists we don't do this. But nonetheless, impressive results. You guys will see methotrexate. I mean, usually methotrexate we think is for people that are about to die, right? But here's methotrexate. Epirubicin, cisplatin, docetaxel, okay, leucovorin, and cetuximab. 1, 2, 3, 4, 5, 6 drug regimen. Is this normal?
It's used by more and more physicians now.
Yeah.
Not the common choice.
Yeah. Do you guys, other people? I mean, we might do TPF or maybe Keynote 48 and then do pembrolizumab, right? PD-1 added to the Taxol and cis. So, but I mean, look at it. I just have to show you guys. Just look at this. Look at that. I thought that was impressive. Look. Did she eat? Did she starve herself?
She can always eat.
Okay. I kid you not. Hopefully this paper gets in. We submit it. We're going to submit it to New England Journal. I had a patient. All right. He's a young guy with a massive tumor in the base of tongue. Really massive tumor. He wanted to be on the 30-grade trial. He had no insurance. So we could not put him, he couldn't even be treated. So what he did is he went home and went on a ketogenic diet. He just starved himself, a strict one. 72 hours, nothing by mouth. 1 hour, eat whatever you want. Then 72 hours, nothing. That entire tumor melted away. He starved the tumor and then melted away. I want to show you guys, so crazy. So when I saw this, I was like, did she eat? Maybe she starved the tumor too. But anyway, look at this. Look at this. This is crazy, right? So Completely gone. So what do you do next now with such a good response? Do you have surgery? Do you go straight to chemoradiation? Do we just say, great response, keep giving chemotherapy? What would people do? Anyone? You would do surgery, okay. Anyone else? So here, what did we do? Oh, let me do the plan. Oh, they went to chemoradiation. I thought your choice dose was interesting. Did you decided 66 gray because?
Because she had a very good response to chemotherapy. We put a little bit area to 70 grays, but most involved area is about 60.
Got it. Yeah, so 66, because 66 is more like a post-op dose, right? And yeah, I think Taiwan likes to do oral UFER, right? This is like 5 of you, right? They do a lot of this. And then definitive RT alone. I mean, I guess plus is really different RT. And then you have, I thought that was great. The target just one side, totally agree. And what was your subclinical? Everything 66? No, right?
Yes.
What? I mean, you didn't want to do a subclinical dose?
We have 3 labeled doses
Oh.
from 66 to about 50 doses, but because the field is so close together, so actually whole area is about 66.
Oh, wow, yeah. Like I would do, our post-op dose, we generally do 50 gray, post-chemo, 50 subclinical, and then dose, so it's a little bit less toxic, but still, this reminds me of that NPC case, you know how you got to there. But anyway, here it is. I thought that was really good. Look at these mean parotid doses. And does anybody have any question about this case? Like, if we went for surgery, we could be complete pathologic response. What do you do? Observation now. But off trial is very hard to do. Okay, that's the next wave. You're going to see a lot of next wave, which is induction, some kind of PD-1, surgery, major path CR, observation. That's why I said they're going to wipe us out. So you got to start thinking indication. It's coming to head and neck as well. So here you did this plan, which I thought that was really good.
I also want to mention
Yeah.
we didn't concurrent chemo because she was over 80 years old and she was a little bit weak. So we suppose that she cannot tolerate CCL2.
Oh, she cannot. Okay, yeah. But I mean, it's pretty amazing already, I think. How many people would treat the contralateral side? Nobody, right? It just be ipsilateral. Very nicely done. I think the ipsilateral is very good with proton. I have a phase 2 randomized study positive. It's going to be presented at Astro. It should be an oral presentation. I don't know, but it's Astro. It's in San Francisco this year. So I was like, oh, I want to go back to San Francisco. But be careful. There are driverless cars in San Francisco. Did you not know that? I've been reading. I'm going to see if I want to ride on one. But so that's what's happening in San Francisco. But okay. And then here, latest imaging. Yeah, look at this. This is amazing. Like the tumor melted. So one thing I learned from here is you don't necessarily need to have PD-1 to get a great response. So when you look at papers that have excellent response, excellent result from immunotherapy preoperatively, this concept is not new. It's actually old, right? It's just that now we have probably better chance of having a response. No buccal lesion. Yeah, so here. Oh, this is the one, right? The timeline that you're doing. Yeah, the timeline. So I think this, because it was M1, you had some bony lesions, right?
Later was the mediastinal lymph node, so we classify her as the M1.
Oh, mediastinal. Did you biopsy them?
No, because the location is too difficult to
Oh.
approach.
Yeah, we try to biopsy, yeah, but yeah, I think this is no active disease. I think this is a great case. I think these two cases give us a lesson. What's the lesson? Which is don't just give up. Just because someone coming with M1, you don't say, oh, palliative. Never give 30 gray in 10. In head and neck, never. 300 times 10, never, never, never. Rather do quad-shot radiation. One cycle, wait, oh, another cycle, another cycle. Because you do 30 gray and 10, you're going to be stuck. If the patient recur, you're going to be stuck, right? And also there's a randomized study from India that compared quad-shot radiation 50 gray in 2, 30 gray in 10, and the quad-shot 1. I use a lot of quad-shot. I don't know if you guys do it, 3.7 BID. You're going to learn this a lot. 300 BID times 2 days, which is 14.8. And then you take a break. That's one cycle. You do a total of 3 to 4 cycles. And we should have a presentation in Astro this year of our results, which is pretty exciting. It's not as good as the definitive cases, but it's what I call aggressive palliation. When you have a very large tumor like that lady, we might consider quad-shot radiation, maybe, okay? So it depends on the scenario. And patients like it too, because they're in the department for 2 days, twice a day, and then they take a break. And then when there's toxic, they're at home. They don't bother you. They don't call you, right? You're just like, oh, everybody's fine. And then they come back for the second cycle. But that's something to think about. Okay, yeah. Then the other thing I wanted to show, this one. Oh yeah, this is one I show. See here, another question is, what is your volume? Is it your pre-chemo volume? Is it going to be the post-chemo volume? I mean, she has such a good response. What is your target? And this happened with surgeon. Okay, the surgeons always think about pre-chemo volume, but more and more they're realizing, wait a second, here's a big defect. You need reconstruction if you do surgery. But when it's like this, what are you going to operate? Are you going to go and then remove the entire buccal mucosa and cheek? Right now, surgeons are moving toward not to do that. I don't know about the Taiwan surgeons. I met some of them. They're pretty aggressive. I don't know if they're here. I had a debate with one of them. I didn't know. He seemed so nice, but then they said that he's actually a butcher. So I was like, ooh, okay. But anyway, so basically here, you might consider smaller volume. Or if you're going to do the bigger volume, go a lower dose, right? Instead of 66 gray. Luckily she did well. You maybe just drop it to 40 gray or 50 gray. Something to think about. That's the only thing I wanted to say. And then, and then the other thing I wanted to bring out. The other thing I thought, one thing to do in between cycles, something to, especially if you're in training or whatever, start collecting blood. Because I do believe in the future of all oncology is going to be liquid biopsy, right? But we just don't have the great technology. I'm going to address a little later, but we don't have the right technology yet. They're still not sensitive enough, but that doesn't mean that's not the future. The future is all going to be about that, liquid biopsy, and how do we dictate treatment based on that? Okay, something to think about. Does anybody have any questions for this?
I can add, this is the case from Professor Lin Jinqing, and I also learned a lot from this case. So the key point here is that we can see the value of induction chemotherapy here, because in previous trial, although they shows mixed results of induction chemotherapy, but still we can see there's a trend that aiding induction chemo can increase local regional control and even distant metastasis. So if we can choose a proper induction chemotherapy regimen, which patient can tolerate well, then we can enhance the outcomes of the patient. And also, second, we can moderate our RT strengths, like dose and field after chemotherapy, depending on the patient's response. Yeah, that's two things I learned from this case.
Yeah, I mean, you really think about it. Do you need to even treat the subclinical? That's what I'm thinking now. Do we even need to treat the subclinical dose region? Because you think what the surgeon does, right? Here's a surgeon, and then if they are shrinking their operating area, they're not going to do, because we're starting to do less surgery. So something to think about, less radiation, because I'll tell you, our crisis in our field is radiation is toxic. People are sick from it. So we have to de-escalate. I really that's what I'm going to talk about. If we don't de-escalate, you still want to do those prolonged treatment, you're going to be wiped out by medical oncology. That's going to be definitely the future. If you look at the trend, breast cancer, hypofractionated, right? Nobody does the 25, 30 fractions. Prostate cancer used to be, 39 fraction, now SBRT. That's the whole trend. Lung cancer, same thing. Head and neck, 7 weeks is not going to work anymore, especially when you have people trying to fight with you. You got to de-escalate, go lower, because less toxicity, but you have to be smart about it. And then you can stay alive. Radiation oncology this year, they're going to cut more funding. More cost to radiation oncology, which is really bad. We got a news a month ago from Astro. I don't know if it pertains to Taiwan, but in America, they're going to want to cut more funds. More reimbursement. So I think we're going to get to a point where, and I think this is worldwide, they're going to give you bundle payment. I have $50,000 for your patient to treat head and neck cancer. And $50,000, everyone's going to want a piece of that pot, right? And then the surgeon's going to take their pot, med-oncs are going to take it, and you have left very little. So when you have left very little, you want to finish your patient fast. And do it well. Of course, patient care is number one. But those are things that are coming. Unfortunately, and then, of course, AI is coming. You guys know, you guys do AI work. I'm doing some AI work. I don't know. You'll see it. We're going to have AI can do all the contouring for you. GTV and CTV. And then I was like, what are residents going to do? So, but if AI comes and AI assistants, I don't know if you guys know this in the U.S., because physics is in bigger crisis, right? Basically, you can, in O center, oh, wow. Is that like time is up? Okay, so I'll just tell you this last thing. In physics, these free clinic, they would hire 10 physicists before, 10 planners. With AI, now they cut it down to 3 planners and they just overwatch the machine doing the plans for you. So that's 7 jobs lost. So that's going to come. Physics is going to be in trouble. I really think so. And then I think radiation oncology, I think it's going to be in a dire situation too. That's why we call it AI assistance, not AI replacement, right? So, but still, that's the world we live in. Yes?
Regarding hypofractionation,
yeah.
What do you think about 55 gray in 20 fractions?
That's like 2 points. Yeah, 55 and 20. Yeah. That's still, how many days is that? 20 days, right? 4 weeks. So I think that's okay too. But then the question is, do you really need it? You mean hypofraction for the primary site?
Yes.
Oh, yeah, I think that's fair. I don't do so many. I do a lot of quad shots, but that's fair too.
Just like this case, if I will do 55 in 20 for the M1 case.
Yeah.
After induction chemotherapy,
yeah.
I will do 55 in 20.
Absolutely, yeah. That would be another regimen. Yes.
And regarding the proton causing the unexpected and more osteoradial necrosis, I think moving forward, we can solve the problem by the LET distribution evaluation. We can do a LET optimized plan. I think we
tried that. I could tell you I couldn't find. They all went back and did it and then couldn't really find the cause. That's why I think it's RBE related. It's not 1.1 biologic effect. But yes, that is one way to do it. Yes. But it doesn't solve all the problem because the high LET region is not where the necrosis is. That's published by MGH, and we looked at it too. I present every complication, but nonetheless, I think we need to continue work on it. I think the future proton is VMAT of proton, arc, because then you have so many angles, right?
Did they evaluate the LET distribution together with the physical dose?
Yes.
The high dose and the high LET distribution, when they overlap, then maybe that's the place causing the problem.
It's not. It's not always. Trust me, we did. I even had a guy, nasopharynx, this side is the high dose. My 50 gray is where the necrosis is. I was like, what? How did it get there?
I have a
right?
Also, soft tissue necrosis at 50 grade.
Yeah, thank you.
Which is not happen in proton therapy.
Thank you for saying that. That's why I want the paper out. But I'm telling you guys the real story. It's been reviewed 4 months in JCO. I'm like, people are not, and I emailed the editor again, but like people need to know their problems. I love proton, but there are problems we need to really think about. But all right, so let's go get some coffee. Okay, thank you so much. Okay.